Now, we have talked about the anatomy of the lymph nodes, the distribution of lymph nodes. We have talked about lymphomas. We have talked about metastatic disease and what metastatic disease do to patients. The prognosis is much worse if you've got metastatic disease, and if the lymph nodes are enlarged and encase important structures like carotid sheath, the prognosis gets even worse because the patient cannot undergo surgery. And if the lymph nodes progressively enlarge and get further and further down the neck, the chances of distant metastasis increases, because if the last barrier, the last defensive line in the supraclavicular lymph node has been breached, malignant cells will enter into the thoracic duct and then into the subclavian vein, after which the patient has distant metastasis. Now let's look at lymph nodes that are involved with metastatic disease. And if you palpate the patient, you do a CT scan, you find enlarged lymph nodes, but at the same time, you do not know where the primary comes from. Now, this is not a very common phenomenon, but in your practice, you probably find a few cases every year whereby a patient comes with lymph node enlargement in the neck, and we have to find out where the primary is. Now, let's see how common this problem is. As you can see, it is not that common. In a registry in the United States, there are about 1 million cases in the data bank. And of this 1 million cases of cancers, 2% of them represent patients with metastatic disease, but the primary disease has never been found. Out of which 55% are adenocarcinomas and 14% are squamous cell carcinoma. In the University of Kansas, there is a much smaller number of patients in the cancer registry, about 21,000. Of the 21,000 in the data bank, 4% of the cases are metastatic disease of uncertain or unknown origin.